Now, this is what I was talking about. You measure the actual pressure which is affecting the alveoli is the transpulmonary pressure. So, how does one measure it? So, esophageal catheters are inserted. Unfortunately, it is an expensive modality, but it is being used for study purposes or certain Western ICUs. So, you put a balloon into the esophagus, and that measures, that is pretty equivalent to the pleural pressure. So, transpulmonary pressure is the pressure differential between the alveolar pressure, the airway pressure and the intrapleural pressure. Now, this is what ultimately produces the barotrauma and atelectator trauma. I'll come to that a bit later. And this is affected obviously by the airway, the compliance, lung compliance, the chest wall and the lung compliance, and the resistance also. So, this is a EPVENT 1 and 2 studies. One was a single center study in which mild forms of ARDS, which were called earlier ALI terminology is no more used. And this was compared the two ventilated modes of PEEP, to low versus high PEEP. And this second was EPVENT, was a randomized controlled trial, 2 randomized controlled trials. So what did they find? That routine use of PEEP-guided PEEP titration offered no benefit compared to conventional PEEP FiO2 titration. And this was based on the esophageal pressure monitoring. Another new technology which has come about is electrical impedance tomography. Now, if you look at the electrodes which are put on the chest wall, which is like a band tied around the chest. Now, the resistance offered electrical resistance. Now, there is an intermittent current which flows through it, alternating current, and the resistance will depend on the compliance of the lung. Okay? So, the lungs are more solid, it will be more resistive. And it creates a radiological sort of picture on the screen, which tells you which of the parts of the lungs are ventilated and which parts are not ventilated. As you can see on the right side, so it's like a radiological image which appears on your ventilator screen. On the left side, you are seeing here the CT scan, which you can see the dorsal part of the lung are consolidated. The right dorsum is more consolidated than the rest of the lungs. And it gives an image, a colored image. Dark blue is more consolidated, orange is more ventilated, aerated. And here again, you can see on the right side of the screen, the lower part of the right side, you can see it's a flat line. That means the resistance is very high, and that is the part of the lung which is going to benefit by opening up the alveoli. The rest of the lungs, you'll be producing more atelectator trauma because of the pressures, higher pressures and volumes to the lungs than what is required. So, by measuring this resistance, electrical impedance tomography, PEEP titration can be accomplished. And in this study, it was found to be useful, although statistically not really that significant. There is another modality called airway pressure release ventilation. It is one of the advanced ventilators do have this. And there is a constant positive pressure in the lungs, and suddenly the pressure is released. When the pressure is released, the expiration happens. So, APRV mode is there in many of the newer ventilators, and this was used to this may improve the oxygenation by recruiting more alveoli. And these were the 3 studies in which this particular study by Zhao et al. From China, it showed significant improvement in ventilator-free days and length of ICU stay, and significant improvement in mortality by using APRV mode. This is one of our own 140 kilo Iraqi patient managing with BiPAP. So that brings me, what is the role of non-invasive ventilation in moderate ARDS? Mind you, it should not be used for severe ARDS. And this was one study of 41 patients. Non-invasive ventilation was given via oronasal mask. 44% of the patients' intubation could be avoided. Role of NIV, again, this mild ARDS, this data is insufficient. If this look at it, reduced intubation rate and mortality in mild ARDS. But again, moderate to severe ARDS, NIV has a very limited role. This is a meta-analysis by Zhang et al. Coming to prone ventilation, I always mention it that prone ventilation should be used much more than what it was being used. Fortunately, this collateral benefit of COVID has been that prone ventilation, everybody has become aware, and it was being used, and awake proning also was being used quite effectively. So this was a trial, multi-center prospective trial in 20 patients with moderate to severe ARDS. In half the patients, one could avoid intubation. So this was awake proning. But if the PF ratio was less than 100, that means it was a severe ARDS, then there is a high risk of failure. And once there is a risk of the failure, then the mortality increases. So as you can see in this, the lowest line here, non-invasive ventilation plus prone ventilation had the best results. This was the first report by us, again in one of the Indian Heart Journal of prone ventilation in ARDS. So prone ventilation, the classic trial was the PROSEVA trial. The role is established. It's a beneficial thing in even moderate to severe ARDS. It improves mortality. Then recently again COVID has brought in this awareness of high flow nasal cannula or high flow nasal oxygenation. This is a humidified device which gives a continuous positive pressure to the airways, very comfortable to the patient, and you may be able to avoid intubation in many of these patients. So this is a classic Florali trial. This is a French trial, multi-center, non-blinded, randomized controlled trial, good number of patients, more than 100 patients in each group, and they looked at the mortality and intubations. Although they did not find any significant statistical difference between the two groups, so it was a negative trial from that point of view, but no question HFNC is a very useful device to have. So what is NIV modalities in ARDS? Well, mild ARDS, although the data is insufficient, you can try the non-invasive ventilation or high flow nasal cannula while monitoring the patient. If the patient is not tolerating, if it is going down, I think within an hour you should intubate the patient and ventilate him. And if moderate to severe, I think it is best to avoid this. It's better to mechanically ventilate the patients. What about steroids in ARDS? Lot of discussion has been going on, and still a lot of discussion goes on. Well, if you look at the meta-analysis by Agarwal, there was no difference in outcome of mortality with the use of steroids. And this was a DEXA-ARDS study, 277 patients, standard care in one group compared with the IV dexamethasone in another arm of the study. And they looked at the mortality and ventilator-free days. And the authors concluded that early administration of dexamethasone could reduce duration of mechanical ventilation and overall mortality in patients with moderate to severe ARDS. But again, it has to be early ARDS. So many of us working in tertiary care hospitals, the patients come pretty late to us, and it may not be really of benefit. Some of the newer modalities for my Western friends who do not use this, but this is ulinastatin. There's a lot of Chinese work in this. And this was a paper by Zhang's group, in which this was a meta-analysis. Again, they found 2,300 plus patients, and they found ulinastatin seemed to show a beneficial effect for ARDS patients treatment, and larger sample size of RCTs are needed to confirm this. I use ulinastatin quite a lot in septic patients. I have shown it does reduce inflammatory markers, and it may improve organ function, but I think still requires more validation. Coming to the final part, the patient is still in refractory hypoxemia in ARDS, what does one do? Well, ECMO is what is left. So this is one of our own patients on a VV ECMO. Most of them would require VV. So there are classic two trials. One was the Caesar trial in Leicester in UK, where patients from all over UK were brought to Leicester for ECMO. There were no standardized mechanical ventilatory strategies before they were brought to the center. And other was a French trial, Eolia trial, a large trial again. And there was some mortality benefit in Caesar trial, but it showed that ECMO can be initiated in centers which are used to doing ECMO, and patients can be transferred safely to these centers from other centers. Although there was no significant mortality benefit, but Eolia trial, 44% of patients who received rescue ECMO survived. Probably many of them would have died if they were not put on ECMO. So again, Alan Coombe is the one who is driving this Eolia trial, is a big name in ECMO. And this meta-analysis for severe ARDS, 90-day mortality was significantly lowered by ECMO compared with conventional management. But nowadays, again, ECMO, one has to be trained for it, your center has to be certified, so that is important. Everybody has been trying to get into the ECMO bandwagon, which I would not advise people to do. There are certain upcoming trials. This is a REST trial, ECOR, extracorporeal carbon dioxide removal, where you put a sort of filter which removes the carbon dioxide without helping oxygenation. So hypercapnic respiratory failure, that is where it will be helpful. Umbilical cord derived mesenchymal cells, the stem cells have been used in ARDS, and this is a supernova trial, ECOR trial, which is multi-center phase 2 trial. And then there is important trial, personalized ventilation, live study. As I said, that every patient is different, every lung is different, every ARDS is different, so you need to titrate and personalize your care. So this was a study meant to do that. It was helped with a CT chest, and you classified the patients subdivided into 4 groups: recruitability, oxygenation patients, lung morphology on a CT scan, on ultrasound, and inflammation, whether it is hyperinflammatory or hypoinflammatory ARDS. Based on this, you decide whether the patient is going to be benefited with a 5 to 6 ml per kilo ventilation or 6 to 8 ml per kilo, and whether this patient will benefit with a high PEEP or low PEEP, because high PEEP is not recommended for mild forms of the disease, and it also depends on the recruitability. So this is the intervention group, and there was a control group, which was a standard of care. The intervention group was the personalized care, and they were divided into focal ARDS and non-focal ARDS. That means global bilateral changes were similar. So lung compliance and recruitability would be similar in that case, but focal, it would be more restricted to one side. And there's 420 patients, 196 to personalized and 204, they looked at 90-day mortality. Although there was no difference in 90-day mortality, but on subgroup analysis, there was benefit of personalized mechanical ventilation. So now going back to the management of ARDS, for mild ARDS, you can manage with non-invasive ventilation or high-flow nasal cannula. If the patient is on mechanical ventilation, you use low to moderate PEEP and low tidal volume ventilation. If the disease progresses to moderate ARDS, then you may require higher PEEP. You do recruitment maneuvers, and you can try. So when it progresses to severe ARDS, if it is only hypercapnic, you can try ECOR or prone positioning with neuromuscular blockade, nitric oxide, and finally ECMO. So this is the algorithm of how you proceed to take care of a patient with ARDS. I will not get into details of this, but there is a standardized way to go about it. There are certain major advances in therapy depending on what sort of trauma is likely to happen to the lungs, whether it is volute trauma because of higher volume, or it is atelected trauma because of continuous, the expansion and de-recruitment to the lungs, because that is what is going to make it worse. Then there is excessive mechanical power as defined by Gattinoni, ergotrauma. There is myotrauma, diaphragmatic dysfunction of the patients can happen. And then there is called SILI, patient-induced lung injury. And then patient can fight the ventilators. You can have a disc synchrony, so what to do for that. So there are standardized therapies and their potential future researchers. And as you know, that alveolar cells do play an important role. So there are a lot of future pharmacological interventions which are likely to happen in the near future. So this is how, over a period of time, the ARDS therapy has evolved. Some have been thrown out of the window, some things have persisted. Low tidal ventilation has persisted. Conservative fluid management based on FACT trial is recommended. PROSEVA trial has shown significant mortality benefit of pruning these patients, and there are certain future trials which you'll see in the coming few years. So where are we heading from here? Well, there's delineation of subphenotypes in ARDS. There is a requirement for identification of novel biomarkers. For kidney, a lot of things are coming up, but for ARDS, not so much. And a better understanding based on radiological findings. So Berlin definition is being accepted now, although there are certain shortcomings. There is no specific pharmacological treatment for it. Precise classification patients based on their own anatomy and pathology would try to mitigate the damage. Thank you very much for your attention.
Thank you. Thank you so much, Dr. Mehta. It's another amazing talk from you.